Hello, everyone. This is the recording for the GI and biliary system and pancreas. So it covers all the disorders and health problems related to the digestive system and to the hepatic, which is liver, and the pancreas. So we'll begin with the common clinical manifestations of the GI tract dysfunction. So the GI, gastrointestinal, and the biliary and the pancreas problems or dysfunctions, they share some manifestations. So these manifestations include anorexia, vomiting, nausea, retching, um, projectile vomiting, uh, constipation, diarrhea. So the retching, which is non-productive vomiting. The projectile vomiting, which is spontaneous vomiting that doesn't follow nausea or retching. So just suddenly, spontaneously, and suddenly the patient start vomiting projectile, and it's associated with one of the diseases. Too many diseases associated with with the projectile vomiting, but one of them is the pyloric stenosis. Pyloric stenosis, and we'll get to that as we move on and discuss the GI tract. Constipation, which is um, infrequent or difficult defecation, so either the quantity or the quality of defecation, the frequency or the difficulty of having bowel movement. So the pathophysiology of the constipation, it could, in other words, the the related factors or the etiological factors, either due to the patient become constipated, either due to the neurologic disorders, functional or mechanical conditions, low residue diet, sedentary lifestyle, and excessive use of antacids. Too much consumption of the antacids that could result in constipation because of the calcium content, in addition to the changes in the bowel habits. So the first manifestation of the GI tract is or the second one is the diarrhea, which is the increased frequency of the bowel movement. And there are three mechanisms or different types of diarrhea based on the mechanism of the dysfunction itself or the manifestation. One is osmotic diarrhea, secretory diarrhea, and the motility diarrhea. The osmotic diarrhea causes would include lactase and pancreatic enzyme deficiency. So deficiency in the lactase or in the pancreatic enzymes could result in the osmotic diarrhea, or excessive ingestion of the like synthetic sugars. The patients who receive full strength of tube feeding formulas like Glucerna or Ensure, or the full strength of the tube feeding formulas, or patients who develop the dumping syndrome, and we will get to that dumping syndrome, which is associated with the gastric resection surgery. The second type is the secretory, from secretion, secretory diarrhea, and this type of diarrhea is usually results from the infectious causes, like the bacterial infections, C. diff, or the rotavirus, or the E. coli. So the uh, small volume diarrhea, as the slide says here, that it's usually caused by an inflammatory disorder of the intestine. Inflammatory disorder of the intestine, like the IBS, which is the inflammatory bowel syndrome, or IBD, inflammatory disease. The inflammatory bowel disease, the IBD, which includes ulcerative colitis and Crohn's disease. And we'll cover this also under the GI tract and this as part of this lecture. The UC and the Crohn's disease. UC, which stands for the ulcerative colitis. And the other type of the IBD is the Crohn's disease. But also it can result from fecal impaction, the secretory diarrhea. Secretory diarrhea also, it can result from the fecal impaction. The last one, which is the motility diarrhea. Causes of this type of diarrhea include like resection of the small intestine, which is called the short bowel syndrome. The fistula that may develop or could develop between the loops of intestine, like intestine to intestine fistula, or IBS, which is irritable bowel syndrome or inflammatory bowel syndrome. And there are other causes like the diabetic neuropathy, laxative abuse. People who abuse the laxatives, they could develop the motility diarrhea. Abdominal pain, which is a symptom of a large number of the GI tract disorders. And there are three different types of abdominal pain. It can be parietal pain, visceral pain, or referred pain. The first one is the parietal pain, which is from parietal peritoneum. Parietal pain internalizes because at any particular point, the peritoneum, which is parietal peritoneum, is innervated from one side of the nervous system. So this parietal pain, it will provide like what's called lateralizing or lateralized, which means it's affect on the one side of the body. Lateralizes because, as I said, that the peritoneum is innervated from only one side of the nervous system. So the visceral pain, which is would arise from distension, inflammation, or ischemia, the pain arising from the stomach, for example, is experienced as a sensation of fullness, cramping, or in the mid-epigastric area. The referred pain, for example, as I said, the slide says it's usually well localized and felt in skin or deeper tissues that share the central afferent pathway with the affected organ. Now, for example, the acute cholecystitis, patients who develop the acute cholecystitis, which is the inflammation of the gallbladder, they may have pain and experience the pain to be referred to the right shoulder of the scapula. Even we know that the gallbladder is located at the upper quadrant of the abdomen. But in acute cholecystitis, the acute inflammation or inflammatory process of the gallbladder, the patient may experience pain to be referred to the right shoulder or to the right side of the scapula, which is the shoulder blade, the flat bone in the shoulder. So clinical manifestations also may include nausea, retching, which is an unproductive vomiting, GI tract bleeding, GI bleeding. It can be upper GI bleeding or lower GI bleeding. When it's upper GI bleeding, which includes esophagus, stomach, and duodenum, lower GI bleeding, which is below there is the landmark for the lower, or the landmark, or the demarcation, or the distinction between upper and lower GI bleed, that the lower GI bleed is below what is called the ligament of Treats, the ligament of Treats. Um, and the ligament of Treats would be located on this slide right here. So that what divides the upper from the lower GI tract. When we say upper GI tract bleeding or lower GI tract bleeding, so the lower GI bleeding, it's below the ligament of Treats, or which is usually the bleeding from the jejunum, ileum, colon, and or rectum. And when we say occult bleeding, which means it's the bleeding that is microscopic, that isn't going to be seen or seen by the naked eye. So it has to be tested in the lab or with a special kit to find out if there is microscopic bleeding in the stool that is occult bleeding. It's different from the hematoemesis, which is hematoemesis, which is the vomiting with blood, and then hematochezia and the melena, two different terms. The hematochezia, which is the fresh blood, and the melena is the old or blood, which is deoxygenated, which is dark colored blood. It's not fresh as the hematochezia and the melena, and both hematochezia and melena, both stool mixed with blood, but the hematochezia will indicate the upper GI bleed, but the melena, which is the dark blood in the stool, that indicates the lower GI bleed. So the dysphagia, which is the difficult swallowing, and it can be either mechanical or functional. The mechanical obstruction, so dysphagia either due to mechanical obstruction or due to functional obstruction. The patient has difficult swallowing. So the mechanical, which is the patient would experience this due to conditions like tumors, strictures, which is narrowing of the esophagus, or the cardiac sphincter, which is the lower esophageal sphincter, or the herniation in the GI tract, such as diverticular herniations. The functional obstruction, which is usually due to the neural or muscular problems or disorders, like the patients who have a difficult swallowing because of the CVA, stroke, Parkinson's disease, achalasia, and we'll get to the achalasia in a few seconds. So this is the difference between mechanical obstruction, functional obstruction, and both will result in or lead to dysphagia or difficult swallowing. The achalasia, which is the denervation of the smooth muscle in the esophagus and lower esophageal sphincter, and the other name for the LES is cardiac sphincter. You can say lower esophageal sphincter, or you can also, it's called cardiac sphincter. So there is a denervation. There is no nerve conduction in the smooth muscle of the esophagus and the lower LES, or the cardiac sphincter. So a form of dysphagia characterized by this achalasia, it's a form of dysphagia, which is characterized by the loss of esophageal peristalses. The esophagus due to the denervation and the loss of the nerve impulses, then it's has decreased and complete loss of the peristalsis of the which would affect the esophagus, and that will result in achalasia. So the disturbed innervation or the denervation of the esophagus or the smooth muscle of the esophagus, that's the pathophysiological changes that will result in the achalasia. So the decreased relaxation of the cardiac sphincter of the LES after swallowing will allow food to accumulate above the obstruction. Next is the GERD disease, or gastroesophageal reflux disease. So GERD is the reflux of the acid and the pepsin, which is called chyme, from the stomach to the esophagus. So the GERD disease develops when the lower esophageal sphincter or the cardiac sphincter zone pressure falls below normal. So conditions that would increase abdominal pressure, it will contribute to the GERD disease. Manifestations will include heartburn, regurgitation of the chyme, upper abdominal pain within like an hour of eating, postprandial, hiatal hernia, which is the protrusion or herniation of the upper part of the stomach through the diaphragm and into the thorax. It can be either sliding hiatal hernia or paraesophageal hiatal hernia. The hiatal hernia, as we said, it's both, two types. So it's hiatal hernia is a type of the diaphragmatic hernia, and as we said, it's a protrusion or herniation of the upper part of the stomach through the diaphragm into the thorax. Now, the two most common types are, the first one is a sliding hiatal hernia, and the sliding hiatal hernia, the patient will develop manifestations like coughing, or what contribute to the hernia or increase the severity of the hernia factors such as like coughing or wearing tight clothes or obesity or pregnancy. All of these factors will accentuate or may make the hiatal hernia, the sliding type, more severe or more heightened. So these are contributing factors that will accentuate the hernia, like coughing, bending, wearing tight clothes, ascites, obesity, pregnancy. The second type, which is the paraesophageal hiatal hernia, which is the, as I said, it says here, the greater curvature of the stomach herniates through the secondary opening in the diaphragm. And so the symptoms would include congestion of mucosal blood flow, which will lead to the gastritis and ulcers or ulcer formation. And the major complication of this type of hernia, which is paraesophageal hernia, hiatal hernia, is the strangulation of the hernia. That's the major complication. And when we say strangulation of the hernia, which is like twisting, and that twisting is going to result in a severe ischemic changes, which means ischemia, decrease in blood supply, blood flow, and that will result in a necrosis. Pyloric stenosis or obstruction, which is the blocking or narrowing of the opening between the stomach and the duodenum. So this is the lower sphincter. The upper sphincter, which is LES or cardiac, between the esophagus and the stomach. And then we have another sphincter, which is between the stomach and the small intestine. So this is the pyloric sphincter. So the patient with the pyloric obstruction, it can be, first of all, it can be acquired or congenital, but patient will manifest or will have exhibit some manifestations like the epigastric pain and fullness of the stomach, the nausea, vomiting with prolonged obstruction, the due to the malabsorption, patient become malnourished, dehydrated, and extreme debilitation, like severe like weakness and debilitation, which is like severe weakness and fatigue. The projectile vomiting is a cardinal sign of pyloric obstruction. So anytime we see pyloric obstruction or pyloric stenosis or obstruction, the cardinal sign and the major sign or manifestation of this disease is projectile vomiting. The disorders of motility. So the intestinal obstruction and paralytic ileus. So an ileus is an obstruction of the intestines. When we say ileus, means obstruction of the intestines. The intestinal obstruction, there are simple obstruction or functional obstruction. The simple obstruction, which is the mechanical blockage of the lumen by a lesion or growth of the tissue or tumors, but with the functional obstruction, which is a failure of motility, which is the paralytic ileus, which is often occur after abdominal surgery. So patient who may develop the paralytic ileus post-op, that is a functional obstruction, not simple obstruction. Because simple obstruction, it's a mechanical blockage by the presence of lesions, tissues, tumors. And this slide shows on the table the difference between the hernia intussusception, which is like telescoping of the tube, which is the small intestine in each other, and the volvulus, which is a twisting like strangulation of the intestine. And then the constriction adhesions, which is adhesions that will grow and develop mostly post-op after the surgery, after like operation or surgical procedure. Gastritis, which is the inflammatory disorder of the gastric mucosa, and it can be acute versus chronic. The most common etiological factor for patients to develop the gastritis is the use of or frequent use or abusing the ingestion or taking the NSAIDs, non-steroidal anti-inflammatory drugs. The NSAIDs, classification of NSAIDs, one of the side effects is gastritis, in addition to other factors which is included in this slide. Now, the chronic gastritis, we have type A and type B. Type A, which affects the fundal aspect of the stomach, and then type B, which affects the antral aspect of the stomach. Both can result from the H. pylori. But A, usually it's due to the elevated level of gas, that result in the elevated level of gastrin. It will cause pernicious anemia, and that's because of the intrinsic factor. The IF is produced from the fundal aspect of the stomach. So the patient will develop pernicious anemia, which is vitamin B12 deficiency. Pernicious anemia, B12 deficiency due to the loss of or failure to secrete the intrinsic factor, because the disease affects the fundal aspect of the stomach, which is responsible for producing the intrinsic factor, which is responsible for the absorption of vitamin B12. That's why patients will develop pernicious anemia. Chronic gastritis tend to develop in the older adult population. And as we said, it's classified as A or fundal or B antral. The chronic fundal gastritis, there's another name for it. It's called the atrophic or autoimmune gastritis. So factors we said that may lead to, which is included in the previous slide, um, like the NSAIDs, for example, because the NSAIDs will lead to decreased mucosal synthesis of of the prostaglandins. So it will decrease the mucosal synthesis, the protective prostaglandin that will protect these linings or the mucosa. So the drug will inhibit the prostaglandin synthesis, which is protective for the stomach or the mucosa of the stomach. Peptic ulcer disease, PUD, which is the ulceration in the protective mucosal lining of the lower esophagus, stomach, and or duodenum. And it can be acute or chronic. The risk factors for the PUD infection include the infection of the gastric and duodenal mucosa with H. pylori, chronic use of the NSAIDs, non-steroidal anti-inflammatory drugs, alcohol, smoking, advanced age, chronic disease like emphysema or rheumatoid arthritis, liver cirrhosis, obesity, diabetes. All these are risk factors for the PUD. Gastric cancer. Um, the the pathophysiology of the gastric cancer, um, so the primary defect is an increased mucosal permeability to hydrogen ions. Now, the other factors would include the use of the ulcerogenic drugs. Ulcerogenic drugs, which include medications um, such as the NSAIDs, the Aleve. Other factors also would include the duodenal reflux of the bile and pancreatic enzymes. The gastric secretions tends to be normal or less than normal. So as we continue going over the ulcers or gastric ulcers, there is also a stress ulcer. So which is a peptic ulcer that is related to severe illness, neural injury, or systemic trauma, which is um, include the ischemic Curling's or Cushing's ulcers. So these are classified under what is called the stress-related mucosal disease. So the first one, actually it's not three. There should be like it's two, but under the ischemic we can put the Curling's ulcer because the ischemic will develop within hours of events like hemorrhage, bleeding, multi-system trauma, multi-system organ dysfunction, severe burns, heart failure, sepsis, septicemia, and severe infections. Now, the patient who developed the stress ulcer due to on secondary to the burn injury, that is called Curling's ulcer. So it can be under ischemic ulcers, but it's different because the causative factor is different, which is burn injury. So patient developed the Curling's ulcer from burn injury. Ischemic from like hemorrhage, bleeding, multi-system trauma, severe um, bur burns is Curling's ulcer. But ischemic and Curling's um, can be under like one classification. And then the Cushing's ulcer, which is usually result or associated with the severe head trauma or brain surgery. So the primary clinical manifestation of stress-related mucosal disease, either ischemic or Curling's or Cushing ulcers, is the bleeding. So patients tend to bleed. So we have to prevent this by putting the patient on a medication. So almost all patients in the ICU will be on the PPI, proton pump inhibitors, which is a classification of medications called acid suppression or suppressors, acid suppressors that will suppress the H2 receptor. So we call them H2 receptor antagonists to suppress the acid production in the GI tract, mainly the stomach. So these PPIs, proton pump inhibitors, that will prevent these type of ulcers when the patient develop, experience pain, burn injury or head trauma or other or hemorrhage or multi-system trauma or any disease that will or injury or trauma or traumatic injury that will result in this type of ulcer. We have to put the patient on prophylactically on a PPI to prevent this type of ulcer. Post-gastrectomy syndromes, which we will focus on one type, which is a dumping syndrome. And that's a rapid emptying of the chyme from the surgically created residual stomach into the small intestine. So patients who would develop the dumping syndrome, also patients who had underwent or experienced the gastrectomy or pyloroplasty surgery, which is the surgery to reconstruct and fix the pyloric sphincter, especially in patients with pyloric obstruction or pyloric disease, which is pyloric stenosis. And it could result in the dumping syndrome from the developmental factors like loss of gastric capacity, loss of emptying control, loss of feedback control by the duodenum when it is removed. So patients who develop this dumping syndrome or experience this dumping syndrome, which is the fast emptying of the food into the from the stomach into being dumped from the stomach into the small intestine without being digested. That could occur or develop in patients post gastrectomy, mostly partial gastrectomy. Maldigestion syndromes. Sorry, malabsorption syndromes. So we have the maldigestion is one type of the dysfunctions belong to the malabsorption syndromes. So the maldigestion, which is a failure of the chemical processes of digestion. So it's the failure of the stomach to digest the food. The absorption, malabsorption, so has to do with the small intestine with the absorption. So there's the failure of the small intestine to absorb the digested nutrients. The pancreas also can be affected, and that results in the insufficiency of the pancreas, and that will result in decreased production of the or insufficient production of the enzymatic of the pancreatic enzymes, like lipase, amylase. Mainly, these are two main ones: lipase and amylase, in addition to trypsin and the chymotrypsin. Causes that may lead or result in pancreatic insufficiency include pancreatitis, pancreatic carcinoma, pancreatic resection, which is the surgical removal or resection of the pancreas, or cystic fibrosis, which is the congenital disease that affects children, and they will be born with cystic fibrosis, and they have a very thick secretions, and which affects all body systems. And the main problem with the pancreatic insufficiency, which is the fat maldigestion. So that's the patient who develop the pancreatic insufficiency will exhibit the fatty stool, and they have also weight loss. Lactase deficiency, and that's an ability to break down the lactose into the monosaccharides. So it will prevent lactose digestion and the monosaccharide absorption. So the fermentation of the lactose by bacteria, it will cause gas and osmotic diarrhea, which means the patient will have a cramping pain and other GI problems. Bile salt deficiency, the most significant problem with this is the poor intestinal absorption of the lipids, which will cause the fatty stool, diarrhea, and loss of the absorption of the fat-soluble vitamins, which includes the vitamin A, vitamin D, vitamin E, and vitamin K, the ADIC. Just remember the ADIC, and that's the fat-soluble vitamins. Deficiency of vitamin A will result in night blindness from vitamin E deficiency. Deficiency of vitamin D, which leads to decreased calcium absorption, bone pain, osteoporosis, and fractures. Vitamin K, which results in a prolonged prothrombin time, petechiae, and bleeding. So GERD disease, the case study, so the first question, what risk factors of gastroesophageal reflux or ulcer disease should the nurse ask about during the nursing assessment? The most important risk factor for the GERD disease and ulcer disease are increased alcohol intake, smoking, increased obesity, especially the truncal obesity, which is the trunk, the upper part of the body, use of certain medications, like the NSAIDs, increased ingestion or dietary intake of coffee, spicy food, caffeine. Second question, what history and physical examination findings given in the scenario can increase the patient's risk for GERD disease and ulcer disease? Now, there are certain things here that we can identify, like the increased intake of alcohol daily, ibuprofen, which is the NSAID, that frequently causes gastric irritation. Patient also noted to have an increased BMI, and during the exam also there is an increased abdominal obesity that has been noted as well. Third question, while doing the physical assessment, identify or list or what are the two important complications of ulcer disease that you can or you should evaluate. The complications that are associated with the ulcer, with the peptic ulcer disease or PUD, increased chance for perforation of the ulcer and bleeding. So we have to monitor for GI bleeding. If the patient has a loss of blood, that can be evident or manifested as decreased blood pressure, hypotension, and tachycardia, increase in pulse rate. As you take the vital signs, hypotension, tachycardia is an indication of the patient is losing blood, bleeding, internal bleeding, if not external bleeding in the stool or bowel movement, like melena or hematochezia, or which would result from the perforation. So perforation of the ulcer and the bleeding are the two major complications. In addition to that, also the patient will complain of increased pain when perforation occurs. When the perforation occurs, then patient may experience increased pain. 4, which has to do with the H. pylori. So the H. pylori has been implicated in peptic ulcer disease. Describe how this H. pylori can increase the chance of PUD. The H. pylori is a gram-negative bacteria, which will be colonized, like dormant and colonized in the mucous membrane or mucous lining of the stomach. Not active, inactive. Colonized means it's inactive for a while. And the bacteria produce enzymes that interfere with the ability of the chief cells to produce the protective mucus lining. So there are chief cells in the stomach that produces the protective mucus lining that will protect the stomach. So this bacteria produce enzymes that will interfere with the ability of these cells to produce this protective enzyme. It's counterprotective, which means this leads to the ulceration. And also, in addition to that, this bacteria, the H. pylori, also stimulates the immune response because it will release the inflammatory chemicals. And these inflammatory chemicals can cause damage to the stomach lining. So each of these two factors will increase the opportunity for damage to the lining of the stomach. IBD, which is inflammatory bowel disease, which includes two different types. The first one is ulcerative colitis, UC, and the second one is Crohn's disease. Both types have some manifestations in common, but they have two different pathophysiology, and there are some distinct also manifestations that can be differentiated, or we can differentiate the ulcerative colitis from Crohn's disease. So the ulcerative colitis, it affects the sigmoid colon and the rectum. Inflammatory bowel disease, chronic disease. It results in a diffuse inflammation, which is different from the Crohn's disease, which has something called skip lesions, and we will get to that in a minute. So this is a diffuse, widespread, diffuse inflammation, which could affect the entire GI tract. And this disease, ulcerative colitis, it will patients will experience the periods of remission as well as the exacerbation, which is the flare-ups. In remission, when the symptoms are very and could be like absent, completely absent. But with the exacerbations, that's when the patient have the flare-ups and they have the heightened level or heightened manifestations, presence of the manifestations. So this type of the IPD, the ulcerative colitis, patients develop what is called backwash colitis, and which is evident in the terminal ileum, and that's during the highest tend manifestations or during the flare-ups. There is also a hyperemia of the mucosa. So the mucosa is hyperemic, which from the increased blood flow, in addition to the edema and swelling of the mucosa in the affected area. So the ulcerative colitis, it could result due to the infections, or it's or immunologic disease, disorder, dietary or genetic, which is this notion that it's the genetic is supported by family studies and the identical twin studies. So research on the family studies and identical twin studies supports the idea that it is a genetic disease. So patient will have a diarrhea, which is a bloody diarrhea, and patient may experience bloody stool or watery stool mixed with blood and mucus about 10 to 20 times a day, with the abdominal cramping too. Usually it's treated with the broad spectrum antibiotics and steroids and the immunosuppressive agents, given that the disease is an immunologic reaction or surgical resection of the affected colon. Crohn's disease, on the other side, it's very similar to ulcerative colitis, but the Crohn's disease, the scientists were able to isolate or identify the one susceptibility gene, like the NUR2 and the CARD15 on chromosome number 16, were identified for Crohn's disease, are responsible for this specific disease. The Crohn's disease, what makes it different than ulcerative colitis is that there is something called skipped lesions which is not different because it's not continuous or widespread, diffuse widespread like ulcerative colitis. It affects only segments of the colon, segments, not continuous inflammation. So the segments of the normal bowel between diseased portions is called skip lesions. So these are the lesions that kind of like skip the disease. You can look at it, this way. Skip lesions and Crohn's disease. These are the segments of normal bowel occurring between diseased portions. So these are the lesions that has skipped the disease process. The patient may develop anemia, and that anemia, these are some of the differences in terms of that patient with Crohn's disease, because it affects the small intestine, in which the part in which the absorption takes place heavily in that area. So that's why the patient will become malnourished, will have significant weight loss. Anemia may result from the malabsorption of the vitamin B12 and folic acid. Liver disease. So liver disease, some of the manifestations of liver disease. The first one is jaundice, which is whenever you see patient or jaundice or patient with jaundice, called icterus, yellowish discoloration of the skin and the sclera, you automatically would think of hepatic dysfunction, liver dysfunction. So either it's due to the extrahepatic obstruction or intrahepatic obstruction. Either it's within the liver or in the biliary tract or biliary tree. Biliary tree, which includes the common bile duct, CBD, PD, which is pancreatic duct, hepatic duct, and the cystic duct, the duct that leads to the gallbladder. So this is called the biliary tree: pancreatic duct, common bile duct, hepatic duct, and the cystic duct. So obstructive jaundice or hemolytic jaundice. Obstructive, that's due to the obstruction, either within the liver, like in liver cirrhosis, for example, or extrahepatic, which is in the biliary trees, like the small stones in the cystic duct or stones in the common bile duct. That is an extrahepatic obstruction. Cystic fibrosis, it's an intrahepatic obstruction. So that's obstructive jaundice. Hemolytic jaundice, that will result from the excessive hemolysis of the red blood cells. And we said that the bilirubin is the byproduct that would result from the breakdown of the hemoglobin and the hemolysis of the RBCs. Viral hepatitis, it can be classified as into different types, to Hep A, hepatitis B, Hep C, D, E, and G. And the hepatitis A, which is the result from it's infectious hepatitis, and it can result from the mode of transmission is the oral fecal route, different from the Hep B, hepatitis B, which is a blood-borne. It can transmit through the blood, not through the oral fecal route. So the pathophysiology of the viral hepatitis, during the acute infection, the liver cell damage results in hepatic cell necrosis. There is a necrotic tissue that will result from the liver or hepatic damage. The inflammation of the area of the hepatic cells. It may interrupt the bile flow because they're supposed to flow from the gallbladder into the cystic duct, common bile duct, and then to the GI tract, the small intestine, to aid in the digestion of the fat. The liver cells, it can regenerate hepatitis A. As we said, it can be found in feces, bile, and partially in the serum of the infected individuals, which means the serum, but mostly the hepatitis A is found in the feces mainly. And the transmission, in terms of the virus, it can also be detected in the blood, but the mode of transmission is the fecal oral route. And who would be at risk to develop the hepatitis A or hep A? People in the heavy crowds, hygiene, and the lack of hygiene and sanitary conditions, food contamination, water contamination. Now, hepatitis B, hep B, which is usually transmitted through contact with infected blood, body fluids, or contaminated needles. So the virus, is a complex structure with 3 distinct antigens. There is a hep surface antigen, or it's called surface antigen, core antigen, and then the E antigen. The presence of the hep B surface antibody indicates the immunity from the vaccine or past infection. Either the patient has been infected, has developed infection or had infection in the past, or has been vaccinated. The presence of the hepatitis or hep B surface antibody, which is the HBS, which is hepatitis surface, the anti-HBS, or the HBsAg, which is antibody. So the presence of the antibodies against the hepatitis B, it indicates either the patient has the immunity. That immunity either from the vaccine, receiving hep B vaccine, or past infection. There are different types of hepatitis, like hepatitis, for example, C is common in patients in hemodialysis with renal failure and who go for hemodialysis 3 times a week. They will be at risk for hep C, and that hep C, it's nowadays it's very it's not that common like in the past, but could be the wound of transmission or the transmission that's from the machine itself, from patient to patient, like cross contamination from patient to patient. Complications: hepatorenal syndrome, which is the patient will have both systems failed, liver and kidneys. Fulminant hepatic failure, which results in severe impairment or necrosis of the liver, and potential liver failure. In addition to chronic hepatitis, cirrhosis, and hepatocellular carcinoma. So we'll focus on the liver cirrhosis in the upcoming few slides. And when we say liver cirrhosis, which is an end-stage liver disease, ESLD. End-stage liver disease is liver cirrhosis. That's the last stage in liver dysfunction. The diagnostic studies, this is just the review. Just take a look at the diagnostic studies and the hepatic function tests, which includes the ELT, the EST, the alkaline phosphatase, prothrombin time. So this is just a review of the functions or the hepatic functions, the test, hepatic function test. Other diagnostic tests for review. And liver cirrhosis. So the liver cirrhosis, it's a comprehensive and a multi-system disease that could lead to a multi-system manifestations, signs and symptoms that would affect all body systems. So the liver cirrhosis, which is in the end stage liver disease, can be classified as Lennox cirrhosis, which is the alcoholic cirrhosis, because also we have the non-alcoholic cirrhosis, like post-necrotic cirrhosis, biliary cirrhosis, and cardiac cirrhosis. The alcoholic Lennox cirrhosis, which is the most common one, which is associated with the alcohol abuse, it can be reversible if the client stops drinking. And there will be a widespread scar formation in the liver. Post-necrotic cirrhosis, which is a complication of toxic or viral hepatitis, patient who had developed Hep A or B or C, chronic type, would result or lead to post-necrotic cirrhosis. Patients could develop that also as an autoimmune disease, which is idiopathic. No identifiable cause or reason or etiology, so it will be autoimmune disease or idiopathic, but also could result from certain types of drugs, medications, or toxic chemicals. So patients who had ingested large amount of acetaminophen, Tylenol, and developed a liver cirrhosis or liver dysfunction, that is a post-necrotic cirrhosis. Biliary cirrhosis, which is associated with chronic biliary obstruction or infection, which accounts for about 50% of all cases of cirrhosis. There is a diffuse fibrosis of the liver with jaundice as the main feature of this type of liver cirrhosis. Cardiac cirrhosis, which would result from the long-standing chronic severe right heart failure. Now, manifestations, as we said, that the signs and symptoms or manifestations of liver cirrhosis, it encompasses and covers almost all body systems. The problem with liver cirrhosis is that 40%, almost like half of the cases of patients with liver cirrhosis, so exactly 40% of cirrhotic patients, they are asymptomatic. They are not going to exhibit any signs and symptoms. So clinical manifestations of liver cirrhosis or end-stage liver disease, the first one is the jaundice. So the local obstruction of biliary ducts by the scar tissue and the regenerating tissues result in jaundice. So it's an obstructive jaundice. Spider nevi, angiomas, and telangiectasias, all these are changes, especially will develop on the nose, cheeks, upper trunk, neck, shoulders, And these changes had to do with the, in addition to the Palmer erythema also, and the spiral angioma and the spiral nevi and the telangiectasies, all of these are, both of these lesions or these changes are attributed to the increased estrogen hormone because of the inability of the liver to metabolize the estrogen. So there is excess of estrogen hormone circulating, and that will result in these skin problems. Bleeding tendency, and that's due to the decreased production of hepatic clotting factors, anemia, leukopenia, and thrombocytopenia. So thrombocytopenia, which is a decreased platelet count, that could also, the anemias would result from the inadequate red blood cell production or the survival of the red blood cell, poor diet and poor absorption of the folic acid, or bleeding from what is called varices, which is one of the complications associated with the liver cirrhosis called esophageal varices. The bleeding, the rupture of the blood vessels in the esophagus, and that's these called varices, and that will result in bleeding, severe bleeding, may lead to anemia. Dietary deficiencies like deficiency in the B12, thiamine, vitamin B12, vitamin B1, thiamine, folic acid, vitamin B12, which is cyanocobalamin. Complications of liver cirrhosis. The first complication of liver cirrhosis is portal hypertension. And this portal hypertension, which is, let me just move on to the next slide to explain portal hypertension. So this is the largest vein in our body called portal vein, this one, which will drain in the liver. The liver is obstructed, liver cirrhosis, cirrhotic, obstructed. So there will be a portal accumulation of blood right here, result in increased pressure, hydrostatic pressure, and that will result in the secretion or the leakage of plasma into the abdomen, and it will also transmit that pressure to the renal blood vessels, to the splenic vein, to the vein that leads or supply or go to the esophagus. The esophageal varices would result from that increased pressure. Increased pressure would lead also to the hemorrhoids. So the portal hypertension, which is the increased blood, extremely high blood pressure inside the portal vein due to the obstruction of the liver, and that results in all these other complications like renal failure or esophageal varices or hemorrhoids. So the varices, which is the small, tiny, delicate blood vessels in the esophagus, will rupture from the increased pressure. In addition to the plasma leaking to the peritoneum, will lead to the ascites. That's why the patient will have the protruded and the distension or the ascites, which is due to the accumulation of fluid in the abdomen. And with that fluid leakage, the protein will leak as well in the abdomen, to the peritoneum. And with the leakage of, or the loss of the protein from the blood vessel, that will make more fluid to be lost because of that decrease in colloidal pressure from the portal vein. So more fluid will leak into the peritoneum. So it's constant and continuous fluid leak into the peritoneum, which is ascites, and that's what makes it very difficult to stop the leakage of the fluid. So we have to give protein, and we have to remove and aspirate the fluid from the abdomen with the paracenteses. Another complication from the liver cirrhosis, which is the high ammonia level. So the patient will develop the encephalopathy because the liver is supposed to convert the ammonia to less toxic material called ammonium. In the liver cirrhosis, the ammonia will stay in as ammonia without being converted into ammonium, less toxic. And the tissues or cells that are very sensitive to the ammonia is the brain cells. That's why the patient with high ammonia in liver cirrhosis, they have high ammonia level in the blood, and this brain cell is very sensitive, and the patient will have behavioral changes, alterations in terms of the mental status, which is altered mental status. Patient may even develop a coma, hepatic coma from the high ammonia level, become combative, become aggressive, patient confused, patient disoriented. That's from the high ammonia level. So let's answer the questions on the liver cirrhosis case study. The first question, anemia and clotting disorders are common features of the alcoholic liver disease. So explain the mechanisms that cause the hematologic disorders. First of all, the liver disease contribute to anemia and clotting disorders in different ways or a number of ways. First of all, the malabsorption of vitamin K contribute to the clotting insufficiency. The alteration in the fat metabolism, it will affect the phospholipid cell membrane of the red blood cell and cause hemolysis. The development of the splenomegaly also. The folic acid deficiency produce megaloblastic anemia. The clotting factors, the liver unable to produce the fibrinogen or clotting factors, and that will lead to bleeding and anemia or hematologic disorders in general. Number two, what GI bleed is associated with the high mortality rate in patients with advanced cirrhosis. Now, the esophageal varices will develop in patients with liver disease, with end-stage liver disease or in liver cirrhosis. So esophageal varices, the delicate, small, tiny blood vessels in the esophagus, which will easily rupture from any minimal pressure, coughing, increased intrathoracic pressure or intra-abdominal pressure will result in bleeding and rupture of these varices. That carries the high mortality rate because of the hemorrhage. Acute pancreatitis is sometimes seen in the alcoholic. So why are tachycardia and hypotension indications of this condition? Now, the acute pancreatitis causes the fluid shift into the retroperitoneal and abdominal cavity. So there is a fluid shift into the retro behind the peritoneum, retroperitoneal, and the abdominal cavity. So that will result in decreased blood volume. So the lower blood volume will result in hypotension and then a compensatory tachycardia, increased pulse or heart rate. Now, number 4 said women are more predisposed to alcoholic liver disease than men, knowing what you do about the metabolism of alcohol. Explain why this is so. Now, the pathways, there are three different pathways in the liver for the metabolism of the alcohol. And all mechanisms produce the toxic metabolite substance called acetaldehyde. All these three mechanisms produce toxic metabolite called acetaldehyde. And one such mechanism is the alcohol dehydrogenase, ADH system. In males, the ADH, the alcohol dehydrogenase system, is depressed by the testosterone. Women, therefore, produce more acetaldehyde and are more likely to receive alcohol-induced liver damage than men. So next case study, the first question: how does the cirrhosis of the liver cause the jaundice seen in this patient? Now, bilirubin is a byproduct of the breakdown of red blood cells. Bilirubin that is in the plasma prior to metabolism by the liver is called unconjugated, and it's a fat soluble. When bilirubin is metabolized by the liver, it becomes water soluble and can be dissolved in bile and released in the small intestine for excretion in the bowel movement. So with cirrhosis, the liver is damaged and there is a change in the normal architecture of the and structure of the stomach, of the liver. There is significant changes in the structure of the liver. So the damage, from necrosis and obstruction, the damaged liver or the damaged cells in the liver will fail to or unable to conjugate the bilirubin normally. So the change in the structure and the architecture of the hepatic cells will cause obstruction of the bile ducts within the liver and prevent the normal flow into the gallbladder and small intestine. Both of these factors will increase the amount of bilirubin that will remain in the bloodstream. And that's why the patient will exhibit the yellowish discoloration, jaundice in the sclera and the skin. Number two, which I did explain earlier about that the cirrhosis damage the liver's ability to function in the metabolism of the of all food products. There's a decrease in the formation of plasma proteins, which will decrease the colloidal osmotic pressure. And due to the changes in the structure and the architect of the liver, there is an obstruction of blood flow with resultant increase in portal hypertension. Fluid leaks into the peritoneal cavity, result in a decreased blood volume and ascites. The decreased blood volume will increase reabsorption of sodium and water. And that increased reabsorption of sodium and water and the increased portal hypertension will increase hydrostatic pressure. That increased hydrostatic pressure with the decrease in colloidal osmotic pressure will increase the leakage of fluid into the abdomen or the peritoneal cavity. And number three, which explains the ammonia and the conversion of the ammonia to ammonium. The liver has very important function, which is the metabolism of proteins. And the protein metabolism will produce the ammonia as byproduct of protein metabolism, where there is ammonia. And that ammonia is supposed to be converted to less toxic material. And when the liver is dysfunctional, then it's would be unable to convert it. So it will stay as ammonia, as toxic ammonia in the blood. And the blood and the brain cells are very sensitive. And that's why the patient will have a altered mental status, confusion, and other problems. So we call this, all these manifestations called hepatic encephalopathy. Hepatic encephalopathy, which is the increased ammonia level in the blood, which will affect the brain cells, and that's why the patient will have a altered mental status and confusion, aggressive, combative, and all the the behavioral changes. That's from the increased ammonia level. Cholelithiasis, which is the gallstone. Most common type is the cholesterol. Risk factors of gallbladder stones, obesity, being female, pancreas problems, age, like middle age. Pancreatitis, it's the inflammation of pancreas, and that's where the enzymes, mostly or main enzymes here are the amylase and lipase. Amylase and lipase, these enzymes cause the in auto digestion, which means that the pancreas is going to eat itself, produce these enzymes to digest itself. So these pancreatic enzymes heavily produced and into the bloodstream and cause injury to also blood vessels and other organs. And manifestations of the pancreatitis, which is epigastric pain radiating to the back, that's very common. And manifestation of the pancreatitis, epigastric pain, localized in the left upper quadrant of the abdomen, radiates to the back. In addition to the other systemic manifestations like fever, leukocytosis, which is elevated white blood cells, hypotension, as we said, from the fluid shift, and hypovolemia and tachycardia. Dehydration is very prominent. Also manifestation due to this fluid shift, due to the or from the effect of these enzymes. Stomach cancer. There are some risk factors associated with the stomach cancer. Sorry. The pathophysiology, and then the colorectal cancer, or cancer of the rectum and the colon, which is the third most common cause of cancer and cause death in the United States for both men and women. CRC, colorectal cancer, cancer of the colon, and colorectal cancer. So Colorectal cancer, CRC, is the third most common cause of death, cause of cancer and cancer death in the United States for both men, men and women. So the CRC accounts for about 9% of estimated new cancers and deaths from all cancers in the US. So here are some of the risk factors. The pathogenesis indicates the two different types of CRC, colorectal cancer, either FAP, familial adenomatous polyposis, and the other one is called HNPCC, which is the hereditary non-polyposis colorectal cancer, or what is called the Lynch syndrome. There's some differences between them. This is the classification systems. Either we use the Duke's classification system or the TNM system, the one that we use in previous chapters, in the chapters that when we discuss cancer. This is the same classification that we use, TNM. T, which indicates the tumor size, and which if there is involvement of the cancer affecting the lymph nodes, if there is an involvement of lymph nodes in the in cancer development or cancer disease, and then M, metastasis, if there is any metastasis to proximal or adjacent or distal organs. Some manifestations or difference in terms of left-sided lesions versus the right-sided lesions. And then the last case study. The first question to review the patient's diet, predict what factors and the dietary choices might contribute to the development of CRC. First of all, the patient's high in refined foods. It is likely that these foods or food choices are low in the antioxidant vitamin A, C, and E that are necessary for neutralizing the free radicals in the body. So this refined foods, they are low in the antioxidant vitamins like A, C, and E that are necessary for the neutralization of the free radicals in the body. Foods also that are typically low in fiber, which will act to bulk up stool volume and assist in removing potential carcinogens from the bowel. Diet high in refined sugars. It will encourage the proliferation of intestinal bacteria that are responsible for converting bile acids to carcinogens. Refined foods that are high in fats stimulate the increased synthesis of bile acids in the liver, providing a greater means for the production of carcinogens by bacteria. So very quick, low in antioxidant, the refined foods. They are low in fiber, high in refined sugar, and high in fat. So the refined foods are extremely carcinogen or can lead to cancer. Number two, the adenomatous polyps or polyps in the adenomatous polyposis. So the adenomatous polyps rise when the intestinal epithelium proliferate, increase in cell size and cell number, the growth of cell growth, and more than what is needed to replace the natural shedding of the mucosal cells. So which means, in other words, that when there is an increased rate of cell growth, so when the cells of the intestinal epithelium proliferate in excess of what is needed to replace the natural shedding of the mucosal cells, that will result in the polyps, adenomatous polyps. Number three, in ulcerative colitis, there is an inflammation. Inflammatory lesions will develop, and there is also a focal hemorrhage and result in abscess. And then the abscess become necrotic, like necrosis and necrotic tissue, and then ulceration. So the inflammatory progression eventually produces the projections of mucosal tissue that will resemble the polyps, and that's why we call them pseudo polyps. Number four, because the colorectal cancer causes the intestinal bleeding, a fecal occult blood test, which is blood test of the feces to indicate if there's any occult blood. So the fecal occult blood test may be used in conjunction with other screening tests to determine the presence of cancer. So the intestinal bleeding is intermittent. It's not continuous. That's why the fecal occult blood may be used in conjunction with the other diagnostic tests to determine the presence of cancer. Now, the patient is instructed to avoid vitamin C supplements, citrus fruits, and red meats for 3 days before the test to reduce the risk of what is called false positive result. Because vitamin C, citrus fruits, red meat, it may affect negatively, or positively, the result. So to prevent or reduce the risk of false positive result, we have to instruct the patient to avoid vitamin C, citrus fruits, and red meat for 3 days before the test. NSAIDs is halted for 7 days because before administering the test. So this concludes the lecture today.